Good morning. Welcome to West High School in Andover Caps. My name is Hope Helfrich. I work at Wesley Medical Center and I'm an RN. I'm in the clinical education department, so I am working closely with Scott Evans to produce this product today. We hope you find it very helpful and enjoyable, and I look forward to seeing the evaluations that you will be doing at the conclusion of this presentation. Your instructors will take care of that for us and getting it to us, but please tell us what was good and how you think we could have improved it. We want your feedback. I am standing next to Dr. Kyle Lindley. He is going to be speaking to you. He's in the Pediatric Medical Director role here for Wesley Medical Center. He has done his med school in the Caribbean, in med school in a residency in Toledo, Ohio. He's worked in New Mexico. He's also been in Missouri and has spent a few years in Kansas City at Children's Mercy. He's been at Wesley a few years, but he's just recently taken this medical director role, and we're so excited. And his wife is also a physician, and they have 5 kiddos. So he's a busy man. Just to the other side of Dr. Lindley is Cindy Chapman. She is a longtime nurse at Wesley. She will allow me to tell you that on April 1st, April Fool's Day, she will celebrate 39 years here at Wesley, and that's quite remarkable. Yay! She started in the newborn intensive care unit, and that's where I met her many years ago. She has chosen to become a neonatal nurse practitioner, and she's also obtained her pediatric nurse practitioner, 2 completely different roles, but things that are very valuable for her as she is the PICU manager. She's also worked at Heart Springs. You might have heard of that organization, and has been here in the PICU area since 2007. So that's about 14 years if I'm doing the math right. So I have your questions, and they do as well. So we're going to turn it over to the 2 of them, and off we go.
You want to start?
Sure. Hey, guys.
Hi.
Like what Hope said, we're just going to try to work through your questions and everything else. And I think there will be a way for you guys to interject and ask questions, and either through the chat or I'm sure we can do other verbal questions and stuff too. We tried to take all of the questions that you guys submitted and just kind of categorize them a little bit more, and we're going to try to get through all of them and answer as many of them as we can, but kind of more through separate categories instead of just going question by question. Really enjoyed reading through all of the questions. They all were really good questions. And then kind of midway through, we're going to show some video kind of the pediatric ICU and kind of talk through that a little bit too. So to kick us off, Nicholas and then a couple of other Andover Capstone students asked questions about the education that you need for this career. And obviously in the pediatric ICU, we have physicians, nurses, nurse practitioners, respiratory therapists, and we have occupational therapists and physical therapists and speech therapists. So we're going to kind of focus from the physician and the nursing side of education, but we know some answers to some of the other specifics if you have those. So from a physician standpoint, you do 4 years of college, then 4 years of medical school, and then after medical school, you start into a residency program. So to do pediatric ICU, you do a pediatric residency and then a 3-year pediatric fellowship after that, and then you can start working in the PICU.
And for nursing, you can go to any kind of a state school and get your associates if you want to begin with, but most everybody is going on to do their BSNs. The associates are pretty much are kind of being phased out a little bit. And honestly, there's some people that go the LPN route to go LPN and then RN. But really, the fastest way is to go through the whole system and just get your RN to begin with. LPNs are not utilized that much in the hospitals anymore. So we really discourage kind of people going that route unless you don't want to work in the hospital. And then there's other opportunities you can do in LPN as you want to do that. But 4 years pretty much gets you your RN, BSN, and your Bachelor of Science of Nursing. And then you can do a couple more years for the Master's of Nursing. And there's different things that are going on now because they're also looking at Doctorate of Nurses, nurse practice, which can also go into your nurse practitioner role. So just for an RN to work in the hospital, 4 years is about it, and that's where you kind of get your Bachelor of Science of Nursing.
Cool. Nicholas Morgan, and I'm guarantee you I will butcher somebody's name. Pretty sure I can do Nicholas and Morgan okay, but I think it's Kayla. And if it's something else, feel free to let us know.
Could be Keela.
Could be Keela. You're right. Anyway, they were asking questions related to what strengths and qualities are ideal for working in the PICU. And then also, what are some requirements or experience that you need to have to kind of start working in the pediatric ICU? So strengths and qualities, especially to get through medical school, you just really need to be dedicated. Yes, you have to have a certain degree of intelligence to kind of get through, but medical school is really how much information can you learn over a short period of time and be able to regurgitate it back out on test questions. So it's way more just dedication and being able to spend the time doing it. But then specifically to working in the ICU, you really need to be able to not necessarily multitask, but be able to know of several different disease processes going on in the unit and be able to flip back and forth between them really quickly so that you can answer questions about different patients almost simultaneously. You need to be really dedicated, a hard worker. You need to really be focused on teamwork, and because really I'm just kind of the team captain here. We all have our own specific roles and do them to the best of our abilities, and really just being open to working as a team is one of the biggest components of this.
And from the nursing standpoint, it's a little bit the same. However, there's a few more qualities that we look for, and across the board from the physician and the nurses, you have to like kids, and you have to show that you can like kids and families because that's what you deal with all the time. And you have to remember that we serve patients from 0 to 18, sometimes through their 22nd birthday. So there's a menagerie of things that you learn throughout the whole thing because these kids can have anything from, the flu to really, really sick patients. So you have to be a multitasker as a nurse. You have to be able to do a lot of things at once and be on your toes and work quickly and really understand the things that are going on all the time, and the teamwork is huge. We get accolades for the teamwork in PICU a lot because you have to be able to work together. You have to think about a 3-year-old that doesn't want to sit still. You have to have other people that are helping you do that too. We also have child life specialists here that help us a lot with that too, which are special people that help us distract, make sure that the kids are doing something, give them video games, that kind of stuff. But teamwork is huge in this, and then also just understanding children. I mean, that's a huge piece of what we do here, and you have to like kids, and you have to like families, and you have to be able to like to talk to people because you can't get through it without talking to everybody.
And then some of the other requirements and experience, from a physician standpoint, you get all of the requirements and experience you need through just the regular training you go through. From a nursing standpoint, I know sometimes we'll hire new grads and other PICUs will hire new grads. So sometimes you'll need a little bit of work experience as a nurse before you can get into the PICU, but not everywhere and not every time. Kind of depends on what the nursing shortage looks like at that point in time and
Totally.
how desperate we are.
Totally.
So just to be quite honest.
Yes.
Anything else?
No, I think that's good. We'll probably hit some more as we go on.
So again, there were a lot of questions surrounding this kind of general topic of what's it like to work in the PICU. So we kind of tried to group them together. Matthew and some other Andover capstone students were wondering what's kind of a day-to-day like activities. And so really we come in from a physician standpoint, we start rounds, we round on every patient after we've kind of gotten sign out from the physician that was here overnight. See all of our patients, go through all of the data, the lab work, x-rays, all of that kind of stuff. and just kind of make a plan for what we expect to happen for that patient that day, medication changes, all of those kinds of things, and collaborate with nursing, dietitians, respiratory therapists, all the other therapists that are involved in the unit, and just make a good plan for the day. And then we check back frequently throughout the day to make sure that it's happening and we don't need to change anything else.
And they also work with a lot of other physicians.
Mm-hmm.
You have a lot of consults that will come in that will be here for certain things that are specific to that patient that the doctors have to work collaboratively with. And so do the nurses, but from your standpoint, you have to do that a lot. From our standpoint, a day in the PICU is pretty standard. You come in, you see your patients, you do your morning assessments, and you take their vital signs, and we do that every 4 hours here. We also, have to check their IVs. We have to check everything about them, do a head-to-toe assessment on every patient. And documentation, of course, is a huge piece of that because we have to make sure that we put everything that we're doing down, and that way someone can go back and look at it, especially physicians, if they have questions about how much pee they've had or how much poop they've had. We're really big on pee and poop here. And that's just the way nurses are. We have to make sure everybody's doing what they are supposed to be doing. And then, we definitely have all kinds of different things going on. We can move patients here or there. Sometimes we have to go to MRI. Sometimes we have to go to CT. Sometimes we have to do to nuclear med or interventional radiology. And one of the questions was, how do you move those patients on ventilators? And we have respiratory therapists that are always assigned to our unit. And those people help with, those individuals help us with the ventilators themselves. So we have a transport ventilator that we hook up a patient to as we go down. So you have to have a nurse and a respiratory therapist if there's a patient on a ventilator to take them down to anywhere. And the nurse and the RT stay with the patient at all times. We don't ever let the patient be out of our sight. So
then we can move them back and forth between beds. Usually there's multiple people, someone at the head of the bed, at least 2 people on the sides, and then someone at the feet to pick up and move and make sure that breathing tube and all of that stays in place. So
because the last thing we want is that breathing tube to come out. So we always make sure that we're making sure that that's happening. Ariana asked what's a typical shift and the longest shift. A typical shift is 12 hours, 7A to 7P or 7P to 7A. We do sometimes in other areas have like a 3A to 3P or a 3P to 3A. The emergency room, they will do all kinds of different shifts. So they have to cover a lot of different shifts. So they will do sometimes 10-hour shifts. Sometimes they'll do a 6 or an 8-hour shift or a 12-hour shift. But most of the time in the PICU, it's 7A to 7P or 7P to 7A.
And that's from a nursing standpoint. Typically, the physician day shift is usually around 10 hours. So like 7:30 to 5:30 in the morning to evening, something like that. And then we'll do an overnight shift, which is a little bit longer, like the 5:30 p.m. to 7:30 a.m. I've worked plenty of places where I do 24-hour shifts. The longest I've ever done, someone asked that question, was I have covered some units for 7 days a week for 24 hours a day. So if there was anything that happened during that period, I was the only one available to do it. So sometimes our shifts can get really long. And then Dana was kind of just asking about how do we keep track of everything going on in the hospital, and it's just a bunch of communication with a bunch of different departments trying to stay up to date. Most of the time it's our charge nurses and director of nursing and nursing manager, those kinds of people that are having those conversations. And even me, when I'm just doing the day-to-day, I don't get bogged down with a lot of that other stuff. I kind of stay more just in the unit. Now we're going to kind of switch over to talk about why we chose career and pediatric ICU, kind of pediatrics in general, and how is it different with adults versus kids. Dana, Nicholas, Leah, Ruby, Victoria, Madison, JC, they were all kind of interested in these topics. I chose it. One, I went to medical school to become a surgeon, and then realized I didn't want to do that lifestyle, mostly a residency, because we started having kids in medical school. And then I helped resuscitate a 27-weeker when I was in residency and fell in love with the NICU, and started thinking about if I couldn't do a subspecialty like one of the ICUs, which general clinic did I like the most? And I enjoyed playing with the kids in the pediatric clinic more than other regular clinics. And so that's kind of why I chose pediatrics, and then switched over to the pediatric ICU. because I didn't like the feeders and growers and that kind of stuff in the NICU, and wanted to do all of the procedures and all of the varied diagnoses in the PICU. So that's kind of how I got here. And as far as adults versus kids, it's totally different. You know, our mantra is kids aren't just little adults. Most of the things that we do aren't FDA approved, and we kind of do a lot based on trial and error and that kind of stuff, and but have learned a lot over time. But it's totally different than treating adults.
And I would say from my standpoint, you know, I started in the NICU, as Hope had told you, and I wanted to be OB or surgery myself, but I fell in love with the babies and just had to stay with the babies. They kind of capture you. And I did it for 30 years, and I loved my babies. But when I had the opportunity to jump up to pediatrics, it's a whole new world. And kind of like what I said earlier, you know, treating all the different things that you do from 0 to 22 is just incredible. The things that you learn, the things that you do, the things that you can learn, and the things that you have to think about. It's just, it's challenging, it's exciting. And when the kids walk out of here and they're somewhat healthy to get out of here, it makes you feel great, because the parents absolutely appreciate everything they can, just as your parents would be very appreciative to you to make sure that you're doing okay, because you know you're their best commodity, you're their love of their life. So we want to make sure that these little bundles get out of here and make sure that they do a great job.
So moving on to the next kind of idea here, Dana Shaya, I believe, what is it, Araceli, Matthew, y'all were all kind of wondering what's the best part about our job. Honestly, for me, it's just being able to be part of a team that with working together, we end up being able to make a huge difference in kids' lives and families' lives. And even the ones that come in that aren't that sick, that get better and get out of the ICU, to the ones that come in just super sick and require basically everything that we have to throw at them, and then end up getting better and getting out of the ICU and still basically at their baseline, the way that they were acting before they came into the unit. But that's by far the best part about the job to me.
I would agree with all of that. Plus, I would add the resiliency of kids. It's just amazing what a kid can do and what they can come out of and how resilient they are. And sometimes they're pretty much the ones that help their parents get through it. The kids do a great job. So I would say all of that plus the kids, they're great. Their minds are wonderful.
Jared was wondering how we learn how to use, Jared was asking about the tools and equipment. I just changed it to our toys, because that's one reason I work in the ICU, is because I have a lot of toys to play with that other physicians don't get to play with. So I get to use toys to intubate people with. I get to use an ultrasound machine to put lines and chest tubes and all kinds of other fun things in. And then we have a video that we're going to show, and as we kind of go through the video, I think Cindy will kind of comment on a lot of the nursing toys that they have to play with.
Yeah, we have a lot of toys. We like our toys and we like our equipment. So yeah, and you learn them out on the job. You know, that's what you do, and sometimes you have to go to classes for it and stuff. So you kind of get that. But right now you're kind of seeing the entrance into our unit and where we go, and this is what it looks like. And we tried to do some colorful. We just re-updated our unit about 5 years ago. It'll be 5 years in August that we moved in. Put some colors and everything. So that's a typical nurse's station and a bed there. We have colorful little things, little circles on our floors to make it look comforting and somewhat like home. I know it's not totally, but those numbers there represent the bed numbers that the patients are in. We have animals to each room as our llama room there. As you see, you can kind of see the bed, and there's that big arm that I think that we'll have another picture of here in a second, but that's our best toy for our kids. It's called the Lincore, and it really gives the kids something right there in their face that they can watch videos, they can listen to music. If it's a baby, we can put lullabies on and it can make them sleep. You see the bathroom there. We have a little toilet that we have in the room. There's a bedside cart, there's a chair and a couch for our families. And then the nurses station is right there. So we set the rooms up so it's nurses, patient, family in each room. So everybody has their own little capabilities there. So that's our documentation screen there for the nurses. And then suction and oxygen and everything that we have there, the little laser thing there. And that's our code blue button, to where we can actually push a button if we have a code blue. And then our 1, 2, 3s of what we would like to see every patient do, because sometimes you get like you don't want to do it. And this is our board where we communicate with our families. Put the name of the nurse and whoever's in charge and the doctor that's on, and then we have all kinds of things that we can talk about. The 3 things that they like about it when they're not here, and then a pain score. That's our EKG monitor. See our stethoscopes hanging there too that we use. And then these are our IV pumps and what we can give patients for there. And then again, our bed for our patients that lays down so a mom or dad can sleep with their patient. And that's the Lincor itself. It has a lot of good things on it. So there's our deer room, as you can see. So, and that's the crib as opposed to the bed that you just saw a few minutes ago. So we do have the cribs, and they have a scale on the end of them, so we can weigh our patient every day. And a good picture of that crib. That's the crib and the IV pump. Kind of see it a little bit closer there. In a minute, you'll see our fun thing. That's just where we can wave our badge to get into our computer screen, so we don't have to always like put in our name and our thing. There's our EKG monitors that shows the rhythms of a patient. Then we have those hanging in each side of the hall of the unit, plus one in their room, plus one up there. This is the fun one. As you'll see in a minute, Scott demonstrates what you can do with this. This is our squishy round, the little water thing. I don't know what you call it, but it moves as you walk on it. The adults like it better than the kids. And then we have a Papa Shot when the children can get out of their beds and stuff, they can get in there. Scott actually did. Yeah, it was bad. But he was 2 out of 3, man. He didn't make all 3. And then this is just kind of the hallway and some more areas that we did to kind of make it look nice. This is the pediatric floor that we have. There's another 30 beds there for the pediatric floor that once our patients are somewhat stable, they can go over to that floor, dock in the box, and then we do have a teen room there that you can see has a great little thing if the kids can get up and go. We do serve a lot of oncology or cancer kids, so they are here a lot. And that's our famous Carl dog. That's our facility dog, therapy dog, and he's awesome. The kids love him, the adults love him, the people that work here love him. He's a great guy. He's been with us 2 years almost here, so and you can see he has a name tag as well. So
going back to the EKG tracings, it's really nice because we can actually pull up a whole 24 hours and then some on it and look at what rhythms may have happened overnight, and be able to kind of look back and document what happened, but also try to figure out how it integrates to what's going on with the kid today. But then you can also put up so that you can monitor the gas that they're exhaling, the end-tidal CO2, and you can monitor their pulse ox and their respiratory rate and all kinds of fun stuff on it. And then if we have an arterial line in place, so we're monitoring the blood pressure beat to beat, then we can have that up on the monitor as well. And we can pull any patient room up at the desk, and so I can sit there and watch things from the desk and not have to go bug the family and everyone else to start with. So
I think we're avoiding communication.
So now we're to Kayla's question about avoiding miscommunication, and honestly, it's just making sure that we talk regularly. And if something's changing in your patient, you just write it down, whether it's from the physician standpoint or the nurse's standpoint. So when we give sign off or sign out or report, whatever anyone wants to call it, we make sure that we kind of talk about everything that's going on and everything that's happened and what got them into the hospital, what's changing, what's kind of the big goals for the patient. And the nurses, as you can imagine, go into a lot more detail at nighttime sign out than what the physicians go through. But then if we're signing out the whole service, so we're coming off of our service week and signing out to another physician, we go through everything very detailed and make sure that the coming on physician knows kind of everything that's going on. But just keeping track of it and making sure that we talk through it all.
And I'll just finish this and then we'll ask, the nurses also call anytime they have a concern or there's something that changes in their patient. They make sure that they're calling the physician or finding them so that we can make sure that we are communicating at all times to do that. And we actually have gone through some training about how to make sure that we can make that happen in terms of cuss words, not the cuss words you're thinking, but CUS, being comfortable. I'm not comfortable with this patient. This patient's feeling, I feel like there's a safety issue, and I have a concern about this patient. So CUS is kind of what we do for the patients for the communication piece.
Does anyone have any questions so far?
I do have a question that I thought you might could answer for my students. I think they are familiar. Can you hear me?
Yeah.
Sure. Yeah.
Okay. I think they're familiar with the concept of an intensive care unit, but what actually happens, or what's the criteria if you're going to transfer someone from regular peds to PICU, or a patient comes to the emergency room? What helps you to decide if they're going to a regular pediatric floor or a PICU floor?
Okay.
So a lot of it ends up kind of depending on comfort level of the regular pediatric floor too. Sometimes there can be kids that are, stable enough to go on the floor, but the floor isn't comfortable with them, so those kids will come here. Big things that make sure that they'll come to the ICU is if they have a lot of metabolic derangements going on. Y'all are more familiar with acid-base status than a lot of parents are, so if the kid is really acidotic, our body has a certain pH that it likes to stay within, just like other fluids and everything else does. So if there's a lot of metabolic derangements, if their electrolytes are out of whack, if they're having respiratory failure where they need a breathing tube or just a lot of extra support from a breathing standpoint, if their heart isn't working well, so they're needing to be on medications for blood pressure, if they have altered mental status so that they're not responding appropriately, those come to the PICU. A lot of the ingestions where kids unfortunately try to commit suicide, a lot of those will come to the PICU to be monitored. And then a lot of traumas come to the pediatric ICU as well. And that's kind of a wide variety of things. There's some other things that will get you there, but does that answer your question?
Yes, that does. I was especially, like, let's say a patient is admitted to pediatrics, and I'm assuming it has to do with the idea that their wellness is going downhill, or for some reason they're going to need more one-to-one or a closer nursing.
Right.
I just kind of wanted you to maybe touch base on the extra nursing care that they would get in PICU versus the regular peds floor.
Yeah, so I'll let Cindy talk on that.
So basically, anything that the patient is not, like Kyle said earlier, not the nurses are not feeling comfortable with the patient being on there. But basically, on the floor, you get 4-to-1 to 5-to-1, 4 patients to 5 patients to 1 nurse. In the PICU, we almost always are 2-to-1, 2 patients to 1 nurse. We do have 1-to-1 patients, and sometimes we even have 1 patient to 2 nurses if they're really, really sick and they have a lot of things going on with them. And so there is that component of, monitoring, making sure, like an EKG or any kind of telemetry, any kind of oral issue, any kind of things that the patient just doesn't look right and they're not doing well and they're lethargic or they're not, they're just not responding well. A lot of times we'll take those patients back over here just so we can give them a little bit more vital signs, a little bit more eyes on, and we're right here next to the unit. And like you saw in the video, the little cubbies where I said the nurses sit, there's a cubby between two rooms. So that's kind of what we plan is to have that nurse right there by the bedside.
Any other big questions?
That's a great answer. Thank you so much.
Sure. Any other questions at this point? We'll just keep running through this if not.
All right. So Ruby was wondering what happens if a kid turns 18 while they're admitted to the hospital, my certification actually goes up to 21. And then just the fact that I have a medical license, I can treat anyone that I want to technically. So I'm not hindered by that. The nurses like to have ACLS approved, but we will even take people up to 25, kind of depending on what's going on in the hospital and everything else. So if they turn 18 while they're in our unit, unless we just want to get rid of them for some reason, we usually keep them in the ICU, and we do try to transition them over to adult status kind of after that.
A lot of them have their specialists that are pediatric specialists too that they want to stay with as well. And any special needs patient, you know, that like through their 25th birthday, we've even had them up to 28 before because they're special needs. And adult floors don't always feel real comfortable with the special needs patients because they're kind of childlike.
Yeah. So. Madison and Shia was kind of wondering how we do this job, especially if we have a family of our own, and what's it like being around kids all day. Obviously, I have 5 kids at home with a wide age range. You just do it. Like, it was harder when I was in medical school and started having a family, but I think that's kind of one of the things that separates people who want to do pediatrics from others. It doesn't necessarily make it that much harder. Sure, you go hug your kids at the end of a hard day when you lost a kid, but at the end of the day, this is just the population that we've been called to work with and to take care of, and so it's just kind of who we are. So.
And it's a career that you have to be committed to and devoted to. As a mom, I've missed a few sporting events. I missed a few things because I had to be here, and this was what I chose to do, and my kids had to understand that. It wasn't always great. It wasn't always fun, but that's what it is. And being the mom of a nurse mom of kids, and I don't know if any of you guys have nurses as moms, but I can tell you that, or dads, because there are dads that are nurses too. I don't want to be and put that in a category, but of course my kids reap the benefits of that by always having to wear their seat belts and always having to wear their helmets and always having to, you know, they're not going to go to the doctor unless they're dying. So that's the other part of it. So I guess everybody has to do that as well. That's the bad part for the kids.
Yeah. So Kayla was wondering if there's special precautions to promote safety. We put kids in isolation that have viruses, so we help them not spread. We wear gloves and gowns and masks. We have special masks to wear when things like COVID are going on. FYI, we had these masks before COVID, and we used them not nearly as frequently. I used to have a beard before COVID, but now because of that N95 mask, I can't. So we're still kind of crying about that at my house. Jasmine and some of the, at least one of the Andover capstone students was wondering, how do we get parents to remain calm and help them cope with the situation too? A lot of that is just communication and being able to read people. And the more you do this, the more you can read people. And sometimes you have to be a little more stern with them, sometimes a little more just touchy-feely and open, and I'm just kind of helping them through the process. But it varies patient to patient, family to family. But as soon as they realize that you really have the same goals that they do, a lot of times it's easier to get them to calm down and deal with that.
And we use our child life a lot for that, and our chaplains. Our chaplains are great communicators to help people take breaks and help them go through what their feelings are. So. And
then Dana and Ariana was wondering about cases that stump us, kind of specifically. Were there times that we don't know what to do, or did we ever think a kid had COVID, but they actually had something worse? As far as, there's frequently times that we don't know exactly what's going on and don't know what to do, and that's when we just rely on physiology, because I know what physiology is not working correctly, and I know how to restore normal physiology, and then that lets me spend time to try to figure out what's going on and what caused that issue. I don't think I've thought a kid had COVID and then they had something worse. It was more typically that we thought they had something other than COVID before this MISC really came out and that kind of stuff, and then it kind of had to flip back to, oh, this actually may be COVID. because we haven't had COVID nearly as long as we've had all of the other diagnoses that we treat. And then what's the worst type of illness that we've seen? Honestly, anything that gets that inflammatory response going, like that MISC, and there's a whole host of illnesses that can do that. But when your body gets super inflamed and you can't control it and it's out of control, you lose your ability to maintain your blood pressure, your ability to breathe, and then your blood doesn't clot like it's supposed to, and you bleed more, and you get this whole host of reactions that honestly is kind of hard to control and restore to baseline. And that kind of leads you to most of the worst disease processes that we see.
Yeah, I would say that. And you want to tell them what MISC, just in case somebody doesn't know what that is?
Sure. Multi-inflammatory systemic response, and it's all secondary to COVID. Yeah. So it's just that inflammatory system gets kicked off, and your body can't control it at that point.
And it isn't exactly an illness. Those are the type of illnesses that we can treat. The illnesses that we can't treat that are probably the worst thing are the child abuse that we do get. So, and that's a part of our job, but it can be kind of one of the worst things that we see. It's not necessarily an illness for the patient, but an illness for what they've been through. So
yeah. So we're going to kind of move on to the last group, and this really focuses on difficult cases or cases that have changed our lives, including the hardest cases that we've seen, and it really addresses how we handle stress and what motivates us. So there were several questions on death as well, and honestly, the answers to these questions is really why I keep doing what I do. The most challenging cases are really the ones that result in death, and being able to push the limits of what we as humans can do to help kids, and knowing that it's really not me just doing this work, that I'm really just kind of a vessel that's really being just used to achieve this work, and to be able, that's kind of what just pushes me forward and pushes me on. The stress is real in the ICU, and it's present every day. I try to mitigate it and try to deny it as much as possible, but you can't, honestly. But the stress and all of this drive to be able to be part of this team is really what motivates the best of us in the PICU to keep going and to keep treating these kids. So Ty and Chaya, Araceli, all kind of ask, what are some of the most challenging parts of our job? And really the answers to the next few questions are going to answer those questions. So we'll look at what are some of the hardest cases that we've seen, and if we get attached to patients or not. I group these together because most of the time the hardest cases that we've seen are the ones that have changed our lives, and the ones that we do get attached to the families on. One case for sure for me was I was a fellow, and this kid's name was Maddie. And I really got close to the family. It was a chronic kid that was on a ventilator. He'd had heart surgery early in his life, and just kind of struggled with chronic lung disease. And he'd been in and out of the hospital a fair amount last year. And then in the summer he came in and was coding, and we were able to get him back, get his heart working again. And he actually did really, really well for the next year to 18 months. And then he ended up coding at home or losing his heart rate and his ability to breathe with the trach. And his family had to bag him on the way into the hospital, and they ended up losing him in the ER. But that was a really hard case for me. I got a ornament from the mom that was a pinwheel that was kind of his. All these chronic kids end up having their little toys or signs, and that was kind of his. And so every year I still put the ornament on my tree and usually send a picture to her of the ornament on the tree and stuff. But that was kind of one of my hardest cases.
We have a lot of hardest cases, honestly.
Yeah.
Every patient that dies is one of the hardest patients that we've had, and I kind of hold those in my heart all the time because I remember every single one of them that we've lost. But you know, having oncology kids, they're here for anywhere from 6 months almost every day sometimes, or every other week. And so we of course get close to those parents. And then we have those specific ones that come in, like Kyle was talking about, the chronic kids that we see them a lot, and especially during respiratory season. My hardest one was a patient that I was actually followed from the NICU and was in the birth of the baby there, and had a very difficult birth, and she was very special needs, and she just came back probably in the last year and passed away here. So I was there for birth and here for death. So very attached to that family and had kept in touch with them, and she was actually 20 years old. So for 20 years, kind of, went through that process. So you become very attached to them. And just to kind of add a little bit from the top, we do try to find things. I encourage my staff, plus I know Kyle and his staff and his doctors do too, but you always try to find something that you can do to make yourself have some downtime, or to find something for that release, because everybody has to have that release, whether it's running, because you just picked that up, right? And some other people do, working out. Some people do massages. Some people do all kinds of things. But we always have to try to find something. We never get rid of it. We always bear it. We always carry it every day. But you just learn how to deal with it.
Right. And Morgan and Leah were wondering specifically about how we handle stress. So you covered your side. And for me, it's my beliefs that really helped me get through this and be able to do my job. Jared was wondering what motivates us to keep going, and really just all of the above.
Every patient
is really
every
what
patient
keeps me going.
Yep.
And Ty and Jasmine were wondering how we cope when children die. And for me, again, it's my beliefs that I'm able to just kind of deal with it and move on. I always say that if it gets to where it doesn't affect me, then I need to stop, because each death should affect us. I probably cry more now than each death now affects me a little bit more than it used to, which is probably a good sign. I'm not calloused yet to any of this, which unfortunately happens to people.
Right. Yeah.
And then we encourage them to get out of this role. So.
And, when I interview anybody to come in as a nurse, that's one of the questions I ask everybody is, what's been your experience with death? Because we lose about 35 kids a year, and it's really important that people understand that it's very emotional. You have to be able to understand it. If you've never dealt with death, it's going to be one of the hardest things you have to do for the very first time. And here at the hospital, we've kind of incorporated a few things to help the families, help the staff. So we have a ceremony that we do at the end of every death, that we give the mom a heart that has a hole in it, so that she can keep that. We keep the solid with the patient. And then we have little hearts that have holes in it that we put the patient's name on it. And we give those to everybody in the family plus the nurses. So it just gives everybody a little bit of a piece of what Wesley can do, because we understand that there's always a hole left in everybody's heart for anybody that's taking care of any patient that passes away. So we try to do something together so that we can make it a real possibility, and everybody understands that we're all in this together.
And 30 some odd deaths seems like a lot, but it's really only about 3%. Right. So 97% of the kids that get admitted to the pediatric ICU get better, which is way better numbers than the adult ICU, which is another reason we
stay in the kids.
Come here instead of kids. Do y'all have any questions? I think we touched on all of the questions, but if y'all have any other specifics, just let us know.
I don't think.
We do.
I was just going to say, I don't think we have any other questions. Well, wait a minute. I heard COVID symptoms can be different and sometimes more severe in younger kids than adults. Is there any difference in how kids are treated with COVID than adults?
I honestly haven't spent a lot of time with adults with COVID, and most of it should be about the same. Honestly, most of the kids with COVID don't really have symptoms, and when they do, we can pick up on it. The biggest concern with kids versus adults is that MISC, the multi-inflammatory system response from COVID, that kids tend to get more so than adults, and we've gotten pretty good at picking up on that, and we have several drugs that have been helping us a lot with treating that.
And the adults have a lot of comorbidities, which kids don't have as much. So I think that's really what kind of exacerbates what the adults do with the COVID.
Thank you.
Hope brought up a question about transplant. We don't really do transplants here. We may start doing some bone marrow transplants in the upcoming years, but not yet. The kids do get transplants at Children's Mercy. We would do heart transplants and kidney transplants, and then you can do several other organ transplants as well. We don't deal with those here, but in bigger centers in the pediatric ICU, that's where you would take care of those.
We do donation for patients that do die. We offer that. It's a mandatory federal government thing that we do have to offer that, but it's done very gently and very systemically. We don't just jump in there because we want to make sure that our goal is to save everybody. So, but sometimes when we can't, then we do offer donation, and sometimes that's the most positive thing that can happen in a very negative situation. So, Julie, do you guys have any questions in your class? We've really enjoyed this. I hope we've captured everything that you guys have done for the questions, and we're always open to more questions. I think you probably have Hope's email and whatever, and so if there's more questions that we can ask or answer for you, we're more than happy to send them back and do that, because after you think about it, and you know, we want to be able to capture whatever you want, and if you're interested in coming to see us, to work with us and be with us later on, we'd love to have you.
Absolutely.
And I'm going to take my mask off.
You can't.
I know
Thank you, guys.
I'm going to do it anyway. I was
Thank
smiling,
you.
so I just
Thank
wanted
you
to
so
smile.
Thank you. We appreciate this more than you will know. And Hope, if you could send us a specific evaluation form that is for PICU, and then we'll get that sent to you, back to you.
Absolutely, that's not a problem. I can
And
probably
guys,
whip that out here tomorrow.
The tour
So-
was fantastic. That's what my kids often say after these. We wish we could have seen more of what the equipment or the rooms look like, and to have had that was wonderful. Thank you so much.
Awesome.
Yeah, I think we have to give a big round of applause to Scott, because
Yes.
he really pulled off that kind of stuff. He's doing a little there in the corner. But really, we're really excited to know that this was something that might have been of value for you. And again, if you have questions, your instructors know how to reach Scott or I, and we can take those questions and send them on. That's not a big deal.
That's
Next
great.
up.
Thank you. Thank you.
We're working with our HR partner, and we're thinking maybe that will be our topic, kind of how to get into recruiting, how to get into the healthcare field from the HR side of it, because I know you want to be one of these too, because these are awesome people. And
we love what we do.
That is very true. So if you have any questions, send them away and send them our way, and then we'll take care of sending you guys the evaluations. And thank you so much for your time today.
Thank you. Bye. Have a great
Have a
day.
great day, guys.
Bye.
Yeah, you too. Bye.